Hello, my name is Dr. Rashan Jayakumar, and this is a case of methamphetamine induced Takotsubo Cardiomyopathy. Takotsubo Cardiomyopathy is a rare disorder associated with hypokinesis and ballooning of the apical ventricular wall. It is unrelated to ischemia. Physical and emotional stress appear to induce TCM. Amphetamines are stimulants that act on the central nervous system by increasing synaptic cleft concentrations of norepinephrine, dopamine, and serotonin. In this case study, TCM is suspected to have manifested secondary to the usage of amphetamines. A 43-year-old with paranoid schizophrenia, bipolar disorder, anxiety disorder, and gastrointestinal reflux disease presented to the emergency department after being found by local authorities vandalizing a church. The patient was uncooperative and had to be restrained. The patient was sedated with IV midazolam and brought to a local emergency department by emergency medical services. A urine drug screen was positive for amphetamines and delta-9 tetrahydrocannabinol. The patient was subsequently intubated for airway protection and transferred to the hospital for further evaluation and management in the intensive care unit. An electrocardiogram showed ST elevation. He was started on heparin infusion and was given nitroglycerin. Emergent cardiac catheterization demonstrated mild epicardial coronary artery disease without any significant flow-limiting lesions. Left ventriculography revealed severe anterolateral, apical, and diaphragmatic hypokinesis of the left ventricle with an estimated left ventricular ejection fraction of 30%. An echocardiogram depicted in Figure A confirmed a left ventricular ejection fraction of 30 to 35% with hypokinesis of the anterolateral and apical wall, very classic of TCM. He was also found to have rhabdomyolysis and sepsis secondary to community-acquired pneumonia. He was managed with aspirin, atorvastatin, intravenous antibiotics, and gentle IV fluids. The patient was hemodynamically stabilized and extubated. A repeat echocardiogram performed 2 days later demonstrated improvement of his systolic function with a left ventricular ejection fraction of 40 to 45%. This can be seen in Figure B. However, there was persistent hypokinesis of the mid-apical, anterolateral, lateral, and apical walls. He was started on metoprolol and lisinopril. He was discharged with instructions to continue taking metoprolol, lisinopril, aspirin, and atorvastatin, and to follow up with the outpatient cardiologist for ongoing management. The pathophysiology of TCM is not well understood. However, literature suggests that stress, coupled with diffuse catecholamine release, may induce cardiac microvascular dysfunction, leading to myocardial stunning and myocardial wall dysfunction. Amphetamines are potent sympathetic nervous system stimulants that induce a systemic stress response. Diffuse release of catecholamine secondary to cholinergic preganglionic sympathetic stimulation of the adrenal medulla can create an intravascular environment that is thought to be associated with the manifestation of TCM. The pathogenic role of catecholamines in TCM appears to be supported by a systematic review showing that 74% of patients with TCM had elevated levels of plasma norepinephrine. This case demonstrated the cardiotoxic potential of amphetamines and the importance of identifying these complications. Thank you for listening to our clinical vignette presentation about methamphetamine-induced Takotsubo cardiomyopathy.